Hello and welcome to my channel. My name is Frank Cusimano. I am a doctor of nutrition and metabolic biology. And if you followed me on any social media, whether it's Instagram or Twitter, now YouTube, you'll know that I'm a true nerd and scientist at heart. So, in an effort to talk about this pandemic and talk about SARS-CoV-2, the virus, and COVID-19, the disease process, I wanted to bring on a real expert. So, as a scientist myself, I can read all the literature, I can read papers, I can synthesize that information and try to present it to you guys, the public, and also present it on Instagram or on social media. But I wanted to bring on experts who are on the front lines, who are seeing patients with COVID-19, who are treating them, and hear what they're going through, and also hear what symptoms they're seeing their patients have, and also how they're tackling the treatments for this disease process. So today I cannot be more excited to have on a dear friend of mine, Dr. Cedric Rutland. He is a pulmonologist and critical care intensivist who is on the front lines dealing with patients that have COVID-19. So we have him on for a short video. So if this is something you guys are into, if it's something you like, go ahead and let me know in the comments below. All right, let's turn it over to Dr. Jamie Rutland.
So my name is Cedric Rutland. I'm a pulmonary critical care physician in Orange County, California. I went to UC Davis for undergrad. I went to University of Iowa for medical school. I stayed there for residency. And then I went to University of Kansas for fellowship. I had my two children in Kansas and then came back to Southern California. I think, throughout my time on this planet or throughout my time in education, I was never at the top of my class. Partly because I understood that it was really about getting better every single day. It didn't really matter if I was on top as long as I got through the class. And then if tomorrow I could say I'm better than yesterday, I was happy. And I continued to do that. And I still continue to do that. And so I think my theme throughout life has just been just keep building on this foundation, right? You have these bricks that you're just laying and you're just putting on some more cement and putting another brick on top, putting on some more cement and you're putting another brick on top. It just creates a strong foundation. And I think within medicine, you need that strong foundation of education so you can apply things and you can apply all things, whatever's thrown at you, which is, we're in this pandemic right now. And because of the way in which I educated myself, I'm able to sort of understand what's going on, why it's happening, how we can respond to it, and what the next steps should be. Even though the steps might be long and might be hard, you still know what the next step is.
Well, before we dive into all about the pandemic, I think it's interesting the point you brought up about, constantly building brick by brick on your educational model. I think students who do that, who look at education from a perspective of they want to learn everything so that it's useful later on, they may not be the ones that are the best on the tests, but they're the ones that continuously have a drive later on to continue to learn because they understand the value of why they're learning as opposed to just doing it for a grade. Because after you get out of school and you're practicing, there is no grade, right? The only thing that matters is you having the drive to understand it for your patients. And if you develop that early on, I think that's what translates. And that's one of the things that I've taken away from you and seeing you do both on social media, but also in your practice.
Yeah, I mean, you're exactly right. You hit it on the head with that. It is about, learning more than it's about grading per se. And so a lot of people will try to memorize things and know things for the test, and then it kind of just goes away. Whereas I was trying to learn things. So when I missed a question on a test, it was rarely because I didn't understand the mechanism. It might have been I didn't read the mechanism. And so I missed it. I didn't get to it, right? So it was never I never skimmed anything. I always went down little rabbit holes to develop this understanding of it so I wouldn't forget it. So you're exactly right. You're exactly right.
Okay, well, let's go down this rabbit hole because I'm just like you. So let's talk a little bit about the pandemic. Now, I want to preface it with you are a pulmonologist and critical care specialist, right? So you are an intensivist, if that makes sense. So on an average day, you do deal with patients that have coronavirus or COVID-19 as their diagnosis. why don't we go back to the very beginning and just give kind of an overview of the virus? You don't have to go into too much detail because I want to go into detail more of the pathology and the physiology, but at least just a little bit about the virus and what you know about it and how we got to where we're at today.
Yeah, I mean, the virus, the coronavirus itself, it's a very common virus. So there's 7 common coronaviruses that infect human beings. You know that. You guys all listening should know that. And the 4 that we see commonly, some are alpha, some are beta. They're really no big deal. They cause maybe up to 30% of the common cold in adults and probably kids as well. And they're no big deal. The issue with the coronaviruses is that they all, at least the alpha coronaviruses, they bind to the same spot within our body. But it's just that now with the more severe coronaviruses, and we're talking MERS, SARS-CoV-1, and SARS-CoV-2. Now, MERS binds to a totally different protein on the T lymphocyte, but SARS-CoV-1 and SARS-CoV-2, they bind to a specific receptor on specific cells in specific areas of your body, which are vital areas for you to be able to survive. And just SARS-CoV-2 can just bind so profoundly to that area. And SARS-CoV-2 is about 88% homologous to SARS-CoV-1. So the SARS outbreak in China in, I think, 2003 is when it was. It's 88% similar to that. And we have to understand that although this is an uncommon moment in our time on this planet, it is a very common moment in the history of the world. This happens. Viruses develop skills, so to speak, to be able to cause massive pandemics. All right. And so in human history, there have been several massive pandemics due to viruses, due to bacteria, due to fungi. And although we don't discuss them very much because we didn't have social media in 1918 or 1956 or 2003 as much, we didn't have all of these avenues that amplify the pathology, right? And now we do. And this is not to say that this isn't a serious situation. It's a very serious situation that is killing a lot of people. This is just to say that this is history. This is human history. And we have to understand that although we try to control certain aspects of our environment and certain aspects of mankind, this is natural.
So let's dive into it a little bit. Now that we kind of got the overview of it, now what are the symptoms that you're seeing in the hospital as a pulmonologist and critical care specialist? You're actively treating patients that have it in Southern California. What are the symptoms that you're seeing primarily, and I guess on presentation?
So on presentation, people are having, fever, asymptomatic type of fever, or they're having fever and body aches and just generally feeling like they have a bad cold or just a cold. But what's interesting, and I actually just did a telemedicine visit about an hour and a half ago, and I was in my gym lifting. What's interesting is patients will have a bad cold, but they'll desaturate. That is, their oxygen saturation will be a little below normal parameters. So, for example, the patient I just got off the phone with that I FaceTimed, I believe she has it. I don't know for sure, but I'm pretty sure that she has it. She says, I feel like I have a bad cold. I'm good staying home. But whenever I walk, like I desaturate to 83% or 85%. But if I just sit here, I'm above 90. I'm at 97%. So again, I think that there are little symptoms that you can tease out of patients to kind of separate the common cold from SARS-CoV-2, which causes COVID-19, which is the name of the disease. So, that's what I see most of the time. Sometimes people will present with loose stool. And again, the reason why I spend all the time I spend studying and learning about mechanisms, one is I love to teach, but 2 is to understand symptoms, right? And so when you think about, wait, why would somebody present with diarrhea? Well, the ACE2 receptor, the angiotensin converting enzyme receptor, is actually located on cells in the small intestine as well, in the epithelial cells there. So it makes sense to me as to why you would present with loose stool. There's a lot of inflammation there. Your cells don't work as well when they get infected, and so they're not absorbing things, and so things just run through your system.
So, okay, that's obviously really great because I think that a lot of people are missing some of those early signs. It's almost like they're presenting with dyspnea on exertion, which is another sign of what you would consider people that have like CHF or heart issues. So it's kind of a picture that you have to tie out from the regular flu, which I think is really important. So on presentation or after presentation, what is the typical disease process, and how are patients, or what is the mechanism behind when a patient goes into what we call sepsis or septic shock or ARDS? I don't know if you want to explain those to everyone out there.
What happens is once this virus enters, let's just say your upper airway cells, okay, it enters your upper airway epithelial cells, which also have the ACE2 receptor. If that virus gets down to your lung, okay, it's going to infect the type 2 pneumocyte. If you guys remember in your pathology classes, if you guys are looking at the alveoli, what you're going to see is these flat cells, which are type 1 pneumocytes, and then you see these sort of cuboidal cells that are kind of right next to it. These are the type 2 pneumocytes. Now, what is their responsibility? Their responsibility is a millionfold. They provide all of the nutrition for the type 1 pneumocyte. They also produce surfactant, right? There's surfactant A, B, C, D. There's so many different types of surfactant. But surfactant's job is to do what? One, it reduces the surface tension so your lung can expand, and so your lung is not stiff and it remains very elastic. Two, surfactant is also an immunological type of molecule. It does tend to lead to the cellular recruitment of white blood cells to come fight off things. So this virus infects that cell, the type 2 pneumocyte. Now, once it infects that cell, binds to the ACE2R, uses the spike protein, uses a protein called furin to cleave itself, to cleave the spike protein. It's a protein that we make. Once it cleaves that spike protein, it fuses with our cell membrane, and then it gets inside, and then it uses its own viral RNA polymerase to sort of replicate and create the proteins it needs to survive and move on. And then it causes cell lysis, and then you get all these viral particles. Now, one of the signs on labs that you'll see an increased LDH, right? Mm-hmm. Why do you see an increased LDH, lactate dehydrogenase? Well, LDH is an enzyme that is used to convert pyruvate to lactate inside the cell. So as you can imagine, when you have cell lysis as a result of an infection and as a result of a creation of viral particles and a lot of virons or whatever, the cells lyse and you get this increase in LDH in your bloodstream. So once that happens, right, your white blood cells recognize that, hey, oh shit, something is around and I got to do something about this. So your white blood cells rush, right? Your neutrophils rush to the area. If it's in your lung, it just so happens that where we provide our body with oxygen, or where we perform gas exchange, is also the area where white blood cells are going to rush. So if white blood cells are rushing to the area to take care of infection as they're supposed to do, you are not going to be able to gas exchange. You're going to get short of breath. If this process continues, and it will, if this process continues and gets sort of out of hand, we call this a cytokine storm. What do we mean by that? Well, just like you called me today and you said, hey, dude, we have a meeting. We got to do this podcast. I'm going to give you a call. The white blood cells do the same shit. But what they do to call each other is they use cytokines. They produce different kinds of cytokines and chemokines, which call different types of cells over to an area. Some of these cytokines and chemokines actually lead to the transcription and translation of proteins to help the immune system, but they also make phone calls. So they call all the cells over and they all rush to the lung. And if everything is cool, they'll rush to the lung, kill the cells that have the virus, kill the virus. Everybody's happy. 7 to 10 days, everything is cool. You feel great and back to normal, because it takes the body 7 to 10 days to produce and manufacture antibodies that can bind to the spike protein and cause neutralization of this infection, right? That's how you kind of get through it. But when you have a cytokine storm, your white blood cells are just going haywire, and they're just rushing to this area, rushing to the lung. And the lung is a huge fucking organ. So then because of the perpetuation of the inflammatory response, you get the same shit happening in your blood vessels. It also turns out that the ACE2R is also present on your vascular endothelium. So the virus is also there infecting cells. If you'll notice right now, you're hearing a lot of cases of troponin elevation, of heart problems, of myocarditis. There's a famous case published out of Europe where this younger patient had a myocarditis secondary to this virus. It's because the virus infects vascular endothelium, which is what your heart is made out of, right? And muscle. So once your immune system rushes to areas of where the virus is present, the cytokine storm can be initiated, and actually it's tough to stop because it keeps going and going and going. And what happens, right? Your lung gets full of shit, full of gunk. You can't ventilate any longer. You can't gas exchange. All right. Your blood vessels become really leaky. So instead of the blood staying inside your blood vessels, everything leaks outside your blood vessels, and you don't generate a blood pressure. When you don't have a blood pressure, organs start to feel like they're not getting nutrition. And what happens? They start to fail. Your kidneys fail. Your liver doesn't work very well. Your brain doesn't work very well, and you're out of it. Your lungs are already fucked. Sorry. And this is what happens in the body when you have this cytokine storm. Now, the problem with science, and it's a huge problem, is you really can only study one thing at a time. There's a billion different cytokines. And so everybody focuses on this cytokine or that cytokine or that cytokine in their studies because you can control the one or two cytokines. But if you try to stop 2 or 3 or 4 or 5 cytokines, then you really don't know what's doing what. But the body is redundant, right? And so the body's going to use several different cytokines to do kind of sort of the same thing. They all don't have a different job, right? It probably depends on their environment and where they're located and blah, blah, blah. But they all sort of kind of do the same thing. And so it becomes difficult. It becomes difficult to treat. Sorry, I went off.
No, that's good. So I think you brought up two things that I want to mention, at least highlight. One is that when you say that the cytokine storm is, everyone is, all those cells, those immune cells are calling their friends or calling other people to come in the area. It's almost essentially, when you use the analogy of a phone call, it's as if everyone in the town decided to pick up the phone and call, and next thing you know, you got a short circuit, starts a fire, and now the fire goes haywire and no one knows what to do because now their phones are out and they have a fire. So that's kind of like the cytokine storm then that damages everything and causes a lot of the issues. And the second thing that I did want to mention, which I think is important, is that a lot of these mechanisms that you're discussing, it kind of lays it up for therapies that people are looking at. But the interesting part that I think you brought up, which is the young case in Europe about the young person that developed myocarditis, I think it goes to show that no matter how young or old you are, that's why we're seeing the span of ages, because everyone has these ACE2 receptors on their vascular endothelial cells. Everyone has them on their lungs. So even if you're very healthy and your immune system's good, your body is susceptible to the virus and you can get infected. Some of you may be able to fight it off a little better than others, but the reality is that there's no way of preventing it, like atherosclerosis, which may, causes years and years to build up. In this case, everyone has the receptors that are there that are ready to be infected with this virus.
Right. And there were several things I liked about that case in Europe. They used molecules that, again, I would think might work. Like they used IVIG in that case, right? IVIG, they're antibodies, right? Within your body, you have virtually 5 different types of antibodies. You got IgA, IgG, IgM, IgE, and IgD, I believe. Nobody really knows what IgD does. But all of these antibodies are floating around. The most abundant antibody is IgG. And the reason it's most abundant is because it probably does most of the protein binding and most of the surveillance in the body. So sometimes people have low IgG levels in their bloodstream, and we call those people common variable immune deficiency. And so we give them IVIG every month, or we give them subcutaneous IgG every couple of weeks. Either way, we treat it that way. But if you notice in this patient that had the myocarditis, and the young patient, they gave him IVIG, which I thought was very interesting.
So let's go through some of the therapies that are working. You mentioned IVIG, and there's also a number of other ones. And for some reason, some of them are still being used on patients and some aren't. I know that each of them has a different mechanism. So do you want to at least mention some of them or the big hitters? And you don't have to go through all of them because I know a lot have been already touched on, or a lot of them have been tried and then discontinued, or for a number of reasons. But
Sure. So again, what you guys all listened to and heard was you heard Trump talk about a medicine called hydroxychloroquine or Plaquenil. So Plaquenil is a rheumatologic drug. No one really quite understands the mechanism, but we use it in malaria. We use it in malaria because chloroquine inhibits the malaria bug from getting into the red blood cell, right? So it can't really get into the red blood cell. So we think that chloroquine and hydroxychloroquine inhibit SARS-CoV-2 from getting into our cells. That's what we think happens. We're not sure. And then if you add azithromycin on top of it, azithromycin probably calms down the immune response. That's probably what it does, but that's what we think it does. We're using it. Am I seeing a big difference? I don't know. If you ask me, the people who are going to get better are going to get better. The people who get worse just get worse. Like, it's not like there's anything that I've seen that's life-saving. The other thing that we use, the other drug that we use, which you guys have all heard about, is called remdesivir. Remdesivir is an antiviral. It inhibits specifically viral RNA polymerase. It's a nucleotide analog. So DNA and RNA are made up of a bunch of nucleotides, right? So you've heard like A, G, T, C, all that stuff. So there's base pairs within your genome. And so these pairs, they need to pair together because eventually they get translated and become certain proteins. And you kind of unzip it and it becomes a certain protein based on which nucleotides are organized together. Now, a viral RNA polymerase is kind of the enzyme that does this. It kind of gets the system ready. And so a nucleotide analog kind of fits into that system and does not allow viral RNA polymerase to continue to do its job, thus inhibiting, right, the production of viral proteins, right? So it's a more downstream effect. And so when I think about it, I look at Plaquenil as probably, if it works, and I don't know if it works or not, but I look at Plaquenil more as a prophylactic drug, and I look at remdesivir as a treatment drug. Now, the thing about remdesivir is we used it in MERS and we used it in SARS, and it tended to have some efficacy there, meaning it tended to work in those patients. The problem with any drug, and especially in drugs in which you're trialing on certain diseases, you think about sepsis, right? The only therapy that reduces mortality in sepsis is what? It's antibiotics within 6 hours, right? How could a viremia or a viral infection be any different? Again, sepsis is SIRS, systemic inflammatory response syndrome, with a potential infection. That's the definition of sepsis. This is the same shit, except it's with a virus. So for me, giving remdesivir as early as you possibly can might turn some people around. It's just that right now, it takes probably 24 to 72 hours before a patient gets their dose. And so, you want to study it, and people are going to say, oh, there's no randomized controlled trials, there's no trials, we got blah, blah. Listen, with the amount of viruses that there are in the world, you're not going to have time to start randomized controlled trials. If you have a drug that you know is safe in human beings and you have a dose in another illness, you should be able to use that drug. And it should be able to be paid for by the insurance companies, and you should be able to start it. We shouldn't have to do a trial on this. We should just be starting it right away, in my opinion, because what else do we have to lose? So, those are the antivirals that we're kind of using. We tried another antiviral called Kaletra, which was lopinavir and ritonavir, but it's the same thing with Kaletra. They didn't get it for 48 hours, but it was a negative study, and this study was published just last week in the New England Journal. Lopinavir is a protease inhibitor. Ritonavir is a liver CYP system inhibitor, so it doesn't allow lopinavir to get metabolized. So the protease inhibitor works, we thought, in this virus because the protease was needed to cleave that spike protein. But what's interesting in my readings, and I don't know if you've read this, but furin doesn't seem to be a protease, but that seems to be the protein that's cleaving spike. At least that's what they're thinking now, but I'm not sure.
All right. Is there anything else you wanted to add? Anything that we missed or didn't cover?
I'll say this. I think for any medical student right now, any fellow, I think that immunology, cell communication is the most important field. And I think that any subspecialty in which you can learn that is extremely important. And I think that any subspecialty that you select, even if it's a surgical subspecialty, you need to learn those organs and the way that they communicate because it is extremely important because that's where medicine is going. Look at this viral pandemic. What is it all about? It is so I just want you guys to pay attention to that.
And I will say that, at least for my medical school, I don't know what other medical schools are doing, but currently I'm supposed to be on internal medicine rotation. We had a halfway quiz that they have in the middle of our rotations. And out of the 30 questions on the quiz, I think about 15 or 18 of them were on coronavirus, COVID-19 symptoms. So it's actually interesting that schools are already testing on it because they know when you get in the hospitals full time or when you get back on rotations or when you do get in the hospitals, clinicians are going to have those questions ready to pimp you because they want to know, did you pay attention to real life events as opposed to just studying, the tried and true stuff in medicine that we've known for years.
Exactly.
All right, Dr. Rutland, I think that concludes it for this episode. Anything that you wanted to add before we close up? I do want to thank you for your time. I know you're a busy man. You're seeing patients every day and you have a beautiful wife and 2 kids. So thank you for taking the time. And if our listeners want to get into contact or follow along or learn more from you, where can they find you?
Oh, you can find me on YouTube at Medicine Deconstructed, and you can find me on Instagram and Twitter and all that jazz at Dr. J Rutland. TikTok, I'm not good at, but you can follow me there if you would like. But we'll get there one day.
All right, perfect. Thank you. Wow, thank you, Dr. Rutland, for being on the video today. If you guys like this episode, if you like this content, go ahead and make sure you subscribe to the channel. Also, leave a comment. Let me know what topics you want me to cover. If it's science related, especially nutrition or anything that has to do with the human body, please let me know. I am an expert in human nutrition. That was my training. So I want to cover it and also bring on experts that can share with you their expertise and their knowledge. So as always, if you guys like this, leave a comment, like the video, and we will see you guys in the next episode.